So I'd now like to talk to you about AV node disease, atrioventricular block, which is really where a lot of the red flag opportunities, for want of a better term, arise. And certainly this is something that in primary care you really need to ensure that you never miss. And the good news is, by asking yourself two simple questions, you will never miss high degree AV block. And those two questions are, can you see a P wave? And is every P wave followed by a QRS? Ask yourself those two questions and you're never going to have an issue. So let's go through this sequentially. There are three types of AV block. The first type is first degree heart block. And very simply, what happens here is you see a P wave and every P wave is followed by a QRS. So that's already an excellent thing, which means there's no evidence of any high degree AV block. This is first degree heart block. But what you do see is your PR interval, that's the interval between the start of atrial contraction, between the start of the P wave and the start of the QRS, is longer than the accepted higher limits of normal of 200 milliseconds. That's more than one large square. So if you see a PR interval where the P wave starts, where at the start of the P wave to the start of the QRS is more than one large square, that's more than 200 milliseconds, more than 5 small squares, that's first degree heart block. Is first degree heart block a concern? No. In isolation, it's absolutely not a concern because it's seen in the elderly. It's also seen in young athletes due to what we call increased vagal tone. They tend to have more stimulus from their vagus nerve from their athletic conditioning. And in isolation, it is absolutely and utterly not a concern. So that's first degree heart block, characterized by a prolongation of your PR interval of more than 200 milliseconds. Now things start to get a bit more interesting when we have second degree heart block, and there are two types of second degree heart block. There is type 1 and type 2. And we can talk about second degree heart block where you have P waves and every P wave is not followed by a QRS. What tends to happen is that in type 1 heart block, that P wave followed by a QRS is then kind of followed by another P wave followed by QRS. But critically what happens is the PR interval prolongs between each of these complexes. And eventually what happens is the PR interval becomes so long that the following complex gets completely missed. So you have a dropped QRS complex. But the key feature in type 1, or what we call Mobitz block, is that you get a prolongation of the QRS interval before you drop a QRS complex. Is this a concern? I'd say this is a kind of an amber flag. In a young athletic individual, we see this again because of high vagal tone. I have to say in an elderly individual, we'd probably consider this as an indication for pacing. And that's something that's now widely accepted amongst the specialist cohort of doctors that typically you refer your patients to. It's curious also to know that racehorses spend 40% of their time in this type of heart rhythm disturbance. That shows that it's a form of physical conditioning. Now, Mobitz type 2 heart block is a completely different story, and that differs in the way I'm about to describe. So you have P waves followed by QRSs, but not every P wave is followed by a QRS. You occasionally drop a QRS. The difference here is that the PR interval is fixed. And what you have is a fixed PR interval followed by a QRS, then another fixed interval followed by a QRS, or maybe you drop a beat straight away. But what's critical is you have a fixed PR interval and the occasional dropped QRS beat altogether. And typically this occurs in a pattern which is predictable, typically something like 2 to 1 block. So you have a P wave, a QRS, a P wave, no QRS, a P wave, a QRS, a P wave, no QRS, but it's fixed. But we'll go through some tracing shortly. And then the one that is an absolute red flag, should never be missed, it's a disaster if that were to happen, is the complete heart block or third degree heart block, where you have P waves and QRSs doing their own thing. So the atrial rate, the P wave goes on at whatever rate it goes on at, say 60, 70 beats a minute, but the P wave has absolutely no relation to the QRS. And what you find is the QRS, the ventricular rate, typically is around 30 to 40 beats a minute and has no relationship with the atrial contraction. And what's basically happened is that the collecting chamber of the heart, where the heart rhythm and the rate is set, is completely divorced from the ventricular pumping chambers, and as a result, the ventricles, which are not responsible for dictating the rate of the heart, have to rely on their own intrinsic rhythm, and it can't do that. It's almost like a backup generator, and eventually it will fail, and this will lead to asystole and circulatory collapse. So it cannot be missed under any circumstances. So in this ECG, I'm showing you first degree heart block, and I'm saying that because what I'm showing you, if you look at the bottom rhythm strip and ask yourself the questions are, is there a P wave? Is every P wave followed by a QRS? And if you glance from left to right, absolutely every P wave is followed by a QRS. The only abnormality is the fact that the PR interval is prolonged. It's certainly more than one large square if you look across that screen, and that is first degree heart block. And another example of first degree heart block here, clearly demonstrating that the PR interval is almost 1.5 large squares here. And it really doesn't, it's a benign finding in most cases, doesn't progress to high level block. It's critical to say that it's a benign finding when it's an isolated finding. And the PR interval remains constant, and that differentiates it from third degree, from complete heart block and type 2, and type 1, Mobitz type 1 second degree heart block. So next I'm showing you an ECG tracing, and I'd like you to look at the rhythm strip at the bottom. And you will see it's an irregular heart rhythm, because actually every now and then we appear to be dropping a heartbeat. And if you look at the bottom tracing, what you will, and I want you to focus on the PR interval, is that there is a gradual increase in the PR interval between the as the heart rhythm progresses before a tracing is dropped. And this is second degree Mobitz type 1. So look carefully and look at each complex in that bottom rhythm strip, and look at the PR interval carefully. First complex, second complex, third complex. And if you compare the fourth complex, the PR interval in the fourth complex, to the PR interval in the first complex that you've visualized before you drop a beat, you'll see there's a complete and utter change in the PR interval. And this is Mobitz type 1, or what we call Wenke-Bach. And it's typically an amber flag. It's not necessarily associated with progress to high degree AV block, but in a symptomatic elderly patient, we would treat it like high degree AV block. In a young patient, we'd ignore it. It's due to high vagal tone. Conversely, on this ECG, what you're seeing is the more sinister type of second degree heart block, where you have a fixed PR interval, and then you have a P wave, but no QRS. So asking yourself the question, can you see P waves? Yes. Is every P wave followed by QRS? And the answer here is every P wave is not followed by a QRS. In fact, you have an alternating phenomenon where one P wave has a QRS, the next P wave has no QRS. And this is a very concerning form of high degree AV block. I would label this a red flag. So even if a patient is smiling in front of you, denying any symptoms of dizziness, loss of consciousness, and the ECG looks like that, you've got type 2 second degree heart block. This patient needs to be in hospital today with a pacemaker being planned for them as an inpatient. It's rare that they're asymptomatic, but certainly I've seen a few cases. Often they will present with dizziness, and there'll be other clues. They may even be syncopal. So this is a red flag ECG, and you can pick it up by acknowledging a fixed PR interval with a pattern where you drop every other or every third heartbeat. This is second degree heart block type 2, and it's a red flag. And here's another example of type 2 second degree heart block. And the other thing I'd say is, if you're not sure whether this is a urgent red flag ECG, share that concern with someone else. There's often expertise within your own primary care team. And certainly for those who've been to the live course, I would have shared my details to suggest that you could share these with me. You'll get a response. And a lot of NHS trusts now have kind of advice lines, which are typically email based, but you can actually speak to a cardiology registrar and come to an arrangement where you can email the ECG across. So the key thing is not to let the patient leave the consulting room until you have satisfied yourself that they are at no risk due to a red flag ECG showing high degree AV block. So the slide here summarizes everything I've just said. And the key issue with second degree type 2 heart block is it can progress very quickly to complete heart block and subsequently asystole. Now on this ECG, I'm showing you really the red flag ECG that can never be missed. It's indefensible. And that's an ECG of complete heart block, where you have absolutely no association. So you have P waves, you're seeing P waves, but every P wave is not followed by a QRS. And actually there is no association between the P wave, no pattern that you can recognize. With second degree heart block, there are patterns that you can recognize as described. But with third degree or complete heart block, the atria are doing their own thing, the ventricles are doing their own thing, they're completely divorced. And the ventricles are not designed to beat at a rate unless the atria are telling them to do so. So the ventricular intrinsic rate is set at 30 to 40 beats a minute, and eventually the ventricles will stop beating. So this will lead to asystole and circulatory collapse followed by death. So absolutely cannot miss this. And the common causes of complete heart block are being elderly, so it's a progressive calcific issue, but also an acute inferior MI, because the right coronary artery that gets blocked during an inferior MI typically provides the sub-branches to provide blood to the AV node. So you may get complete heart block in the context of an acute inferior MI. So those patients typically will not be presenting to your practice. They'll be presenting to specialist care via an ambulance with central crushing chest pain, dizziness, and a remarkably slow heart rate. And this ECG here shows someone who has complete heart block. The P waves are doing their own thing, the QRS are doing their own thing, but they've got markedly ischemic changes in leads 2, 3, and the chest leads, suggesting myocardial ischemia, which is probably related to a very large right coronary artery. So again, just another summary slide stating what I've already told you, summarizing everything about what third degree heart block is, what the atrio-ventricular, what the atrial rate is, what the ventricular rate is, and the take-home message is you can never ever miss this ECG.